Good morning. My name is Phil Caushaj. I'm the past president of the International Society of University Colon and Rectal Surgeons. And I'd like to take this opportunity before starting my webinar today to welcome you all to the 30th Biennial Congress of the ISUCRS, which will be held in Yokohama, Japan on November 11th to November 14th this year. It is looking like it's going to be the greatest meeting that we've ever had. It will be in conjunction with the Japanese Society of Coloproctology, their 75th meeting, and it will have a dizzying array of international speakers, conferences, sessions. I think you'll all look forward to it, including the social program in Japan. So welcome, and I hope you attend our meeting. It really will prove to be one of the great meetings of our society. Today I'm going to speak about diverticular disease, and this is something that will impact most of us. There seems to be a growing incidence in Western countries as well as throughout the world. For those of you that don't know, this is my president, Donald Trump. He's building a wall to keep me in. And God save my country. That's all I can say. So, 65 to 80% of the population by the age of 80 will have some form of diverticular disease in the United States. Mostly that's diverticulosis and not the inflammatory version. 1 to 4% will develop acute diverticulitis. 1 in 200 will need an operation for this disease. Hinchy 3, and we'll talk about the classification system later, or 4, usually undergo resection. Resection has a high morbidity and a mortality, both from the operation and from the septic complications of the disease associated with it, as high as 27%. It usually involves the sigmoid colon, or the left side of the colon, although it can involve the entire colon. It can perforate and involve the small intestine, the omentum. It can develop enterocutaneous fistulas, and it can fistulize into the bladder and cause colovesicular fistulas. The Hinchy classification, which was initially a radiologic classification, was released in 1978, essentially said that for complicated disease, you could have a small, confined pericolic mesenteric abscess. You could have a large abscess. You could have purulent peritonitis with a perforation, and you could have feculent peritonitis associated with a perforation, being the worst stage, stage 4. This is from the original drawings by Hinchy, demonstrating how a peridiverticulitis can perforate and cause these complications. Now, CAT scans sort of evolved in the late 70s, early 80s, when I was still a surgical resident, and over the years have had a significant impact upon this disease, both in terms of making the diagnosis of the disease, now being the preferred radiologic study of choice, to interventional and therapeutic modalities to treat the disease. I once had a professor at Hopkins say to me, "You look at the x-rays, I'll talk to my God to decide what to do." I never brought up Hinchy classification to him again. But here's an example from a laparoscopic case of a small purulent collection in the pelvis in a patient with diverticulitis. We simply aspirated this. There's no obvious hole. We placed a drain, and we converted what was going to be a laparoscopic, an open or laparoscopic Hartmann procedure to a semi-elective procedure 10 days later. Now, the classical teaching is Following the initial attacks will lead to a 20 to 40% readmission rate. Complication rates following acute diverticulitis exceeded 50%, and therefore our professors and our mentors taught us that 2 hospitalizations warranted an elective 2 hospitalizations for acute diverticulitis. Then you added the Hinchey classification, which upon presentation demonstrated complicated disease to us, and this sort of led our decision-making tree. Now remember, as this dogma was being expanded, interventional radiology was in its infancy, and many institutions didn't have this. So a patient who had a CAT scan with a pelvic abscess often required a surgical intervention to drain the abscess and resect the disease. That's no longer the case today in 2020. I show this photograph, and I've shown it many times. This was a dear friend of mine who was transferred to me in 1991 with acute diverticulitis. And at that time, I had just started doing laparoscopic colon resections, and it was a Friday afternoon, and the surgeon sent them to me so that I could, I believe, relieve him from the responsibility of taking care of this delightful man, and on the hope that I could, quote unquote, do it laparoscopically. As you can see, this is an old-fashioned 2-hand assist operation with an ileostomy. However, I would stress to you today, I would attempt to do this patient laparoscopically because it might be better for him. The morbidity of his incision, the morbidity of a major operation, and keeping this patient in the ICU for what it was months at that time is evident to all. So my hypothesis in thinking about diverticulitis has changed. When we do operations for inflammatory bowel disease, they are to treat the complications of the disease process and not to try to cure, for example, Crohn's, or we can cure ulcerative colitis, but should this also be the case for diverticulitis? The indications for Crohn's are well known to this audience: perforation, hemorrhage, obstruction, fistulization, sepsis, being refractory to medical therapy. You know, in a very elegant study where they looked at 285 patients who presented with radiologic evidence of diverticulitis, you could see that 239, the majority of the patients, needed no further intervention, whereas some presented with abscesses or recurrent diverticulitis that required additional therapy. How do we treat it? It's really not the topic of this conversation, only to tell you that antibiotics are improving and antibiotic regimens are improving, but there are data that exist now that say that you might not even need antibiotics for mild degrees of diverticulitis. So going over the basic principles, essentially, acute diverticulitis will occur in a small subset of patients, and only 4 to 35%, depending on the study, and it's more like 4 or 5%, will present with perforated disease. Generalized peritonitis in the past was a surgical emergency, and Hartmann's procedures in the past was the workhorse. However, back again, historical dogma, 10% require surgery, Hartmann's being the gold standard, but looking at Hartmann's as a morbid operation with stoma, reoperation, incisional hernia, peristomal hernia, and a significant percentage of the patient, as I wrote in the mid-90s, will fail to close their stoma. Now, to do a Hartmann's procedure properly, you resect the area, you close the rectal stump, and there are complications to the rectal stump. You form an end colostomy with the morbidity as I discussed. Now, Ferrer looked at selective non-antibiotic treatment. Now, once again, This is for mild diverticulitis with no antibiotics or antibiotics, and found that he could do that. Now, before you all start doing patients treating diverticulitis without antibiotics, remember there were a lot of problems with Ferrer's study, which is why I didn't really spend a lot of time on it. There was selection bias. They didn't tell you how they made the diagnosis. Not everyone had a CAT scan. And there are lots of reasons why people can have left lower quadrant abdominal pain, from irritable bowel syndrome to inflammatory bowel disease. So let's go back onto our topic. When should we operate? Should we operate at all? Under what circumstances? What's the optimal timing? And I like to think of diverticulitis as three groups: uncomplicated, complicated ongoing, and complicated resolved. Indications for immediate surgery to surgeons are clear. Someone who comes in with peritonitis, who's hemodynamically unstable, who doesn't respond to IV fluids and antibiotics immediately, or who's admitted on medical therapy, IV antibiotics, and while getting his x-rays and his evaluation deteriorates clinically, or in patients who have unrelenting obstructive symptoms. And this is not immediate surgery, but it's semi-urgent surgery. So as Ward Griffin, the head of the American Board of Surgery for 50 years, said to all of us, rather than await the inevitable perforation, he should be advised to have elective or emergent surgery. He spoke to us as Moses, and as he spoke, my country followed. Well, what constitutes a previous episode of diverticulitis? Is it pain? Is it response to antibiotics? Is it hospitalization? Evidence on a CAT scan? And in some of the literature, you will find these things are not clear. But the best study I've looked at is this study that really started the revolution, which is from the Kaiser Permanente group in California. They took 3,100 patients who presented with X-ray evidence, CAT scan evidence of diverticulitis, who were admitted to the hospital, and found 82% of them did not need surgery. And of that 82%, only 13% recurred. And of that group that recurred, 71% required surgery and 30% did not. So a significant portion of patients who were being admitted to the hospital in the Kaiser system did not need emergent surgery for diverticular disease. And it changed the way we thought about diverticulitis, because a required colectomy was no longer an objective endpoint. Then Anaya and Flume from Washington State really did an elegant work looking at the risk of emergency colectomy and colostomy following hospitalization for diverticulitis. And they looked at the hospital discharge database of the entire state of Washington, over 20,000 patients in a 14-year period, and they found following the initial admission, there was a 19-20% recurrence rate, and only about 5% required emergency colectomy and/or colostomy. And keep this number in mind, that 5% requiring emergency colectomy and colostomy, because that number will hold true in other studies as well. They did find a subgroup that seemed to require surgery for a more aggressive disease, and that was in patients, as you can see on this Kaplan-Meier chart, with age under 50. And there have been other papers suggesting a more virulent form of diverticulitis in younger patients under 50, and there are still some authorities that are offering cautionary warnings that intervention after one attack in a younger than 40 age group is warranted. However, when you really look at all that data, you'll see that there is a significant selection bias. Many of these patients have atypical presentations. There's a high rate of misdiagnosis. There's a high rate of a delay in diagnosis, and patients that are managed as outpatients seem to be excluded, with really high rates of surgery for patients with uncomplicated disease. Something doesn't smell right in the data, and I would recommend to you that you not follow suit in this. This was a young picture of me, not one of my happier moments. Now, diverticulitis in the young, as Janes wrote in 2009, even if it's demonstrated in some studies that younger patients have a statistical higher recurrence rate, this does not mean they have therefore broken through some crucial barrier and must be offered elective surgery. The chance of emergency surgery or stoma surgery is still very low. And I'd like you to remember that. It's still about 5%. So why offer someone an operation with a significant morbidity when there's a low probability that they will need a stoma? Now, what about the complicated resolved subgroup? You know, you've got a patient comes in, it's got an abscess, you put in a drain, it resolves the disease. You know what to do. You don't know what to do. In this patient who fails, you know what to do. So the problem with the Hinchey classification is it does not address patient comorbidities. It does not address the physiologic status of the patient. It does not address risk factors for anastomosis. And the Europeans have tried, I think, and I give them a lot of credit for attempting to come up with a classification system that includes all of these human physiologic and clinical parameters, as well as the radiologic parameters of the Hinchey classification. But sadly, to date, there has been no system that has done so elegantly. How do we treat it still today? Antibiotics, interventional radiology. We've now added laparoscopic techniques, and we've always had surgery. Now the question is timing and what type of surgery. And there are those that say, do we need surgery at all? And should we abandon the Hartmann for an anastomosis and an ileostomy? Well, Hinchey 1 and 2 is easy. They're treated by antibiotics, percutaneous drainage. Hinchey 3 may be treated with laparoscopic lavage in the literature, and Hinchey 4 requires resection, still reviewing all of the literature. So after elimination of acute sepsis, the interval elective sigmoid resection, whether you perform it laparoscopically or open, is to be considered. So to me, the initial thrust of the patient who presents with acute diverticulitis is not to focus in on whether we resect or not. It's how the patient responds to sepsis control. Can you obtain sepsis control with laparoscopic drainage and antibiotic therapy, and then convert an emergency into a semi-elective consideration? Or does sepsis control fail with minimal techniques that require then major resectional therapy? A Hartmann is still the gold standard for controlling sepsis, and that is something that we should not forget. Whether you do the Hartmann laparoscopically or open, I'm not discussing, but a Hartmann is still the best way to control sepsis. So what is laparoscopic lavage and drainage? It was first described in '96, and it's laparoscopic exploration, lavage with heated saline. Yes, we still do that. Drainage of the diseased colonic segment, and they, in their initial description, did an extensive adhesiolysis, mobilization of the small bowel, and search of the perforation. I've never done that operation. And I've learned to realize that something that sounds like it's too good to be true may be too good to be true. Patients following lavage, simple lavage and drainage, were getting better without elective surgery. So this then led to the Dalala data. And in here, this was an initial diagnostic laparoscopy demonstrating there was Hinchey 3, followed either by randomization into drainage or Hartmann's. They had 139 patients. 83 patients were randomized in the lavage or open Hartmann's procedure. The demographics were equal. The operative data, it was quicker to do a lavage, an hour versus 2 hours for Hartmann's. And their outcomes were reflected by shorter time in recovery room, shorter length of stay for lavage, less drainage for Hartmann's, and no mortality or long-term re-op differences in either group. Okay. The primary endpoint were the number of interventions, but they couldn't discuss that in their initial paper because they didn't have they didn't have the complete follow-up. Exclusions were a liability, but no selection bias seemed evident. So in the Dalala trial, laparoscopic lavage versus Hartmann was performed in 9 centers in Sweden and Denmark, and it randomized to these 83. Initial short-term outcomes, great, no significant differences. Second, long-term follow-up and looking at primary outcomes, re-ops, secondary outcomes, number of re-ops, readmits. Well, what they found is that lavage had a shorter length of stay, fewer stomas, and a reduced number of re-ops. Similar safety profile to Hartmann's. So then we added the Lola trial, which was a therapeutic lavage versus sigmoidectomy, multi-center, parallel group, randomized, open label, 34 teaching hospitals in Belgium, Italy, and the Netherlands. The trial had a second arm, the DIVA, comparing Hartmann's versus sigmoid resection and primary anastomosis. They looked at 90 patients assigned in the 2-1-1 to lavage, Hartmann's, and primary resection and anastomosis, with the major endpoint being major morbidity and mortality in a 12-month period of time. The re-op, dehiscence rates, abscess, urosepsis, and all of this were followed MI, multiple system organ failure, and then on the basis of major inpatient morbidity of 35 to 18%, the study was terminated. The conclusion was that laparoscopic lavage was not superior or equal in efficacy to resection. This then led to the next. The Scandinavians have had a lot of fun with this. The Scandiv trial, which was a multi-center, 2-group, open label, pragmatic superiority trial performed at 21 hospitals in Norway and Sweden. Classification based on evidence of perforation, and this was mostly looking at Hinchy 3s. When they looked at 132 Hinchy 3s, analyzed with a few Hinchy 1s and 2, which shouldn't have been in the stuff, there was no difference in morbidity and mortality. The endpoints did not differ between groups. The re-op and missed cancer rates seem to be higher in laparoscopic lavage, which doesn't make sense, and we'll talk about in a little bit. And their conclusion was no evidence to support laparoscopic lavage for treatment of perforated diverticulitis. So when you look at the prospective randomized controlled trials of laparoscopic lavage, do a deeper dive. The early termination of the ladies' Lola because of higher rate of in-hospital reinterventions. However, the long-term serious adverse events were the same. Reintervention was not unexpected because some of these patients were drained, continued to have sepsis, and needed to have surgery. We would not consider that a failure today. We would consider that part of our plan. And that sigmoidectomy remained the definitive procedure to reduce sepsis. Although sigmoidectomy is not curative, there's a 6 to 9% recurrence of symptoms post-surgery. Resection is superior to controlled sepsis. 35 to 45% of the stomas given for a Hartmann are not reversed, and the morbidity is higher for resection than it is for laparoscopic lavage. Well, what about the missed cancer issue? This I don't understand, because in every patient that I've seen in our hospitals that have had acute diverticulitis, that have had a mass or a phlegmon in the left lower quadrant, once the inflammation is resolved prior to surgical intervention, they end up having a colonoscopy. And that resolves the issue. There is no missed cancers. What about the Scandiv trial flaws? Since this is the Scandinavians' most influential study, in the laparoscopic lavage group, the surgeon was a registrar in a third of the cases, and a colorectal surgeon in 46%. And there is a provider bias, not a selection bias, in this study, and this introduces a really significant Well, we'll send the young guys to put in the drains, and we'll do the real surgery. It should be done by the same individual. So, are there high-risk patients with diverticulitis? Is there a subgroup of patients that, if they have these diseases, we really should operate on, maybe with 2 or 1 episode of diverticulitis? The Mayo Clinic found 4: steroids, immunosuppressed, collagen vascular disease, and diabetics. And they showed that these patients had a significant evident issue with perforation, morbidity, and mortality with diverticular disease. So this subgroup of patients probably should be operated on. The Mayo Clinic also then showed patients with phlegmon and abscess with a previous history had a higher risk, and patients with free perforation also had a higher risk of having a problem. So after recovering from an episode of diverticulitis, what is the risk for an individual requiring an urgent Hartmann's procedure? Janes did epidemiological studies and said the incidence was 1 in 200. If you take that with the study from the University of Minnesota, although this was a small group, looking at the size of the abscess, how immunosuppressed, how long were you drained, how many previous episodes, you really come up with there are some subgroups that need intervention. Well, what are the indications today for elective surgery? Well, there would be ongoing symptoms of inflammation, patients who have non-responding to antibiotics, quote-unquote grumbling symptoms persistent, the patients who are immunosuppressed, multiple documented episodes greater than 3, perhaps with an increasing crescendo of tempo, patients with a symptomatic stricture, persistent fistula, unable to rule out cancer, and lifestyle, airline pilots, ocean captains. What about the optimal time of elective surgery? You want to operate in a period in which the inflammation is significantly reduced. As if sepsis is under control, the inflammatory response is reduced, that gives you the best chance to perform a minimally invasive operation, which is less morbidity for the patient, and to create an anastomosis not in the presence of purulence. So early elective surgery can happen. You might have to consider a higher conversion rate, but a delayed colectomy after 6 weeks of an acute episode in a patient who's responded to antibiotics without any other recurrence is ideal. How do we know that? Well, good judgment comes from experience, and experience comes from bad judgment. That's how we know that. So you have to be somewhat follow your own institutional guidelines when you're going to consider intervention following an episode in which there was a Hinchy 3 diverticulitis present. The answer to Ward Griffin was the bold surgeon's patience, more importantly, takes all the risks. He does all the calculations. So how does it present? We can have symptomatic, uncomplicated disease. These patients, we don't know what the right treatment for them is. Is it mesalamine? Is it medications that are being used for Crohn's? Is it antibiotics? Is it some combination of fiber? In addition to this, we don't know. We know there's also recurrent uncomplicated disease. Again, what's the best treatment for it? Is it medical? Is it anti-inflammatory agents that have been used for IBD? We know that somebody with smoldering diverticulitis who has no symptom-free episode needs surgery. We know that people with complicated disease need surgery. The complicated presentations are abscesses, small, large, mesenteric pelvis, perforations, purulent, fecal, fistulization, stenosis, hemorrhage. So now we're sort of becoming like Crohn's disease. We're operating on for the complications of diverticular disease, which include if they're refractory to medical therapy and the frequency of episodes. So we now have a Shakespearean dilemma: to resect or not to resect. And how we do that resection. Are we bringing a Hartman's, which is a shotgun, to a fly swatter fight? I don't know. When you look at the data by Gregerson, which he looked at the short-term mortality, readmission, and recurrence of a patient who was admitted with acute diverticulitis, he found in his study that only about 5% were readmitted with acute diverticulitis. That's significant. He also found that the same steroids, diabetes, complications in patients need to be considered as being a prognostic. So Clarenbeek did also a four-year analysis of risk factors of indications of patients. And what did he find? That in their study, stenosis, fistula, persistent abscesses, recurrent diverticular bleeds were significant indications for surgery, along with abscesses, stenosis, failure of conservative, that means antibiotic therapy. And their results were, they had a 13% morbidity. Again, 1 in 5 had previous surgery for diverticular disease in their study. That stunned me. So his risk factors, you've heard it already before: immunosuppressed, chronic renal failure, new one, collagen vascular. So what do? What do? I once spent 5 hours getting this pig to sit on a toilet seat at Johns Hopkins Hospital. I thought it was the highest achievement in my young medical student career. I've done greater than this. So what does the literature show? Medline literature search with references added. Diverticular disease is 25% of the Western cultures. It's increasing frequency. After the first episode, nearly 1/3 recur. After the second, 1/3 recur. Notice that that's similar to someone who's undergone surgical treatment for Crohn's disease in the past. Perforation is common in the first episode, not in the subsequent episodes. After recovery from the first episode, 1 in 2,000 patient year follow-up, the risk is very low. Surgery has real complications associated with it. 25% of patients will have recurrent symptoms post-op after resection, and there's no evidence to support elective surgery after 2 attacks. When you look at Flums, who's done some brilliant epidemiological work from the Western United States, his SCOPE collaborative, which was a cohort study of 2,700 patients from 2009 to 2013, about 29% had complicated disease as an indication for surgery, and about 70% had episode-based indications. And they were trying with education to teach the surgeons of Washington State that the indications had changed from 2 episodes to 3, and wanted them to document the indications preoperatively as part of their trial. So at the beginning of their trial, 1/3 of the surgeons failed to meet the indications of 3 or more episodes of diverticulitis, although over time, 50% of the procedures met indication. And what did they find? An annual rate of emergency resections remained unchanged from 5% to 5%. Think about that. That's the number we keep seeing in all the data. The patients who have diverticulitis, who presents with an emergency that requires immediate surgical intervention, it's about 5 or 6%. What does the American Society of Colon and Rectal Surgeons recommend? Well, they strongly advise against elective resection for uncomplicated acute diverticulitis. The first episode, they do think you should, for a first episode that's non-resolving or smoldering, or multiple episodes or complicated disease on presentation, in these two subgroups, they will allow surgery. So most emergency surgery, if you think about it, occurs at episode 1. It's the patient that shows up into the emergency room with left lower quadrant abdominal pain and a CAT scan which demonstrates free air under the diaphragm, along with a fluid collection, which upon laparoscopy is evidence of either purulent or feculent peritonitis. And that patient, in most hospitals in the United States, and I would dare say throughout the world, gets a Hartmann's done open. What's the likelihood of recurrent hospitalization? It's about 5 to 13%. So not all of these patients, yeah, they may have symptoms. They're not all going to require hospitalization. What's the incidence of emergency colostomy? 5%. What's the elective resection rate now? Anywhere between 5 to 10%. What's the elective resection risk? Is about 1 to 3% versus a stoma for an anastomotic leak at about 25%. So a patient must be able to tolerate recurrent infection. And I personally had this issue with a family member recently, in an 80-year-old individual who presented with acute diverticulitis. We took to the operating room, and there was purulent Hinchey 3 diverticulitis. We aspirated the pus, we placed in a drain, we did not mobilize the small bowel, and at the time of that surgery, which was at midnight, we made the statement, if not better, physiologically, in 12 hours, in this 80-year-old individual, we will immediately proceed to Hartmann procedure. The patient responded to fluids, antibiotics, and drainage, and 10 days later, we did a laparoscopic resection with primary anastomosis and no protective stoma in this 80-year-old. So we used our laparoscopic lavage as a bridge. However, it was not as an excuse. We had a plan. The plan was if X, then Y. If the patient does better, we will operate. If the patient does not do better, and I think that's the important take-home message. If you're going to use laparoscopic lavage, you have to have a plan B and follow the patient carefully to make sure you know how they're responding to your therapy. So if a patient fails non-operative with a phlegmon or an abscess or inner loop abscess, they don't need laparoscopic lavage. They need a resection. Do it however you want, laparoscopically or open. Laparoscopic lavage is used in the management of Hinchey 3, can lead to more interventions and thereby cause an issue with the ladies' trial, but doesn't increase the morbidity and mortality. A laparoscopy as an intervention is not that big of a deal. So the old dogma, you needed 2 episodes of hospitalized diverticulitis, gone. Contemporary data fails to demonstrate any preventive surgery unless you're doing it for the airline pilot or the riverboat captain, actually decreases the incidence of emergency surgery at a population level. I love this slide. You'll have to excuse me. I'm myself today. So the future is not what it used to be. What do I do? Now, this question has been asked to me. All of our patients are taken to the operating room where they undergo a diagnostic laparoscopy. And if you're a Hinchey 4, you get an attempted laparoscopic or open Hartmann procedure performed based on the degree of inflammation and ease and difficulty of the procedure. Hartmann 3, minimal contamination. We do not do an adhesiolysis. There is no bowel mobilization. We place drains and we get out. The patient gets better with observation in the ICU. We will then, and they respond to the conservative therapy. We will then try to do a staged semi-elective operation during that hospitalization, hopefully without a stoma. If there is still inflammation present, we will do a primary ileostomy. If there's no improvement in 24 to 48 hours, you got to take the patient back to the OR. Because remember, laparoscopy is not the preferred method of sepsis control. A resection is the primary method of sepsis control for these patients. Laparoscopic lavage is, for me, a bridge to convert from a mandatory Hartmann to a semi-elective resection with no stoma if possible. I don't believe it is definitive therapy for most patients. To cut to cure, ad catechumen perclunum. The objective in operating on Hitchy 4 patients, 3 or 4, is to stop the ongoing sepsis. If drainage alone from a small perf that's sealed off and minimal contamination, great. And if you can't do that, resect. And notice, I'm not discussing whether you resect laparoscopically or open. I don't care, whichever you're good at. So what are the indications now? Ongoing acute diverticulitis, the smoldering, bleed, fistula, stricture, can't rule out cancer. So what does the Cochrane review say? They looked at the electronic databases from 1946 to 2017. They had 2 attendings review all the studies, looking at confidence intervals and confidence coincidence intervals. They only found 3 trials with 392 participants met criteria: Switzerland, Netherlands, Germany. They found that inclusion criteria differed amongst all of the trials, with one trial, believe it or not, doing this for Hitchy 1, another trial for Hitchy 2, and almost all trials with mixed indications. So the results from the Cochrane review demonstrated that there is no good evidence to support or refute the safety and effectiveness of laparoscopic surgery versus open surgical resection for patients with diverticulitis. The data is just not there. At present, the use of laparoscopic surgery must be tailored, I believe, to the patient, because it's not laparoscopic lavage is not the best source of sepsis control, and in an elderly patient with multiple comorbidities, the best may actually be a laparoscopic resection or an open resection and not the placement of drain. Well-designed trials are necessary with standardization of indications, technique, and do you do an adhesiolysis? Do you not do an adhesio? I don't, because I think it opens up a sealed hole. But what's the answer? And the postoperative management. The review of this literature, looking at 28 studies, looking at laparoscopic lavage versus resectional, there was no consensus of technique, colonic hole management, definition of failure, and need for additional surgery. The data heterogeneity and the severe selection bias in all of these limited randomized controlled trials, we obviously need an excellent, well-designed international trial. Not that it's going to give us the perfect answer, but may guide us towards the arc of truth. The data at present is worthless. Standardization of technique needs to happen, and you need to individualize this in your own institution with clear plans and clear actions. So I'd like to thank you for listening to my webinar on acute diverticulitis. And yesterday when we performed this live, I was happy to take many of your questions. I want to once again welcome you to coming to Yokohama and joining us there. For those of you that are hearing this, we would like to welcome you to the International Society of University Colon and Rectal Surgeons. It's a great society representing all surgeons, both academic and clinical surgeons throughout the world. It is the only international organization. Our current president, Dr. Chun, will welcome you in Yokohama, Japan, to probably the greatest meeting that we have held. So I hope to see you in Japan, and I thank you for the privilege of your time. Thank you.
Thank you very much, Phil, for a wonderful lecture on the current strategies in diverticular disease. One question is, what do you define as a microperforation, Phil?
To me, a microperforation is a radiologic finding on CAT scan where you see a tiny bit of air or adherent to the bowel, adjacent to the bowel. I do not define it as free air under the diaphragm.
So essentially, you will manage this as an uncomplicated diverticulitis.
That is correct.
Okay. And talking about antibiotics, I mean, you did touch on the fact that there are some randomized studies, although they may be trial biases. But in your practice, do you think you might switch to not using antibiotics in patients who might have uncomplicated diverticulitis, or do you still need more hard evidence?
You know, I need more hard evidence, number one. But number two, to be quite honest with you, Joe, here in the United States, most colorectal surgeons do not see the uncomplicated diverticular disease. These are being managed by our primary care doctors and or gastroenterologists. So we're not often in the loop to make that decision.
Okay. And in terms of the, if a patient needs a resection, I think you stated that most patients in today's practice will have a Hartmann's procedure, of which probably 50–60% of those will probably never have their Hartmann's reversed. Do you think that perhaps, perhaps where possible, we should be offering a resection and primary anastomosis with divertent stoma, and perhaps diverticulitis or surgical diverticulitis should be managed by a specialist who might feel more comfortable or more skilled to do that procedure?
Joe, that's absolutely correct. I think that the management of diverticular disease should no longer be the bailiwick of all general and colorectal surgeons, because I think that in these patients, the presence of a stoma is significant morbidity and changes the quality of life they have. So consequently, most of these patients, if they can, I'm not talking about the patient that shows up at 3 o'clock in the morning with free air under the diaphragm and septic. Yeah. That's a Hartmann, and that can be done by anybody. But the decision making for patients who need that semi-elective or semi-urgent operation should be done by a colorectal specialist.
Okay, agreed. Touching on the young patients again, I think we all agree that a young patient probably has a higher chance of recurrence over their lifespan. But I think we probably all agree that from your talk that the likelihood of complications is no higher than the older patient. Is that correct, Phil?
That's correct. You understood me correctly.
Correct. So in your practice, how would you advise a patient who is young and has non-complicated diverticulitis as to what to do? Someone less than 50.
So that person who shows up in my office immediately gets referred to a gastroenterologist that I know and trust, who will evaluate that patient for other diseases. Does he have collagenous colitis? Does that person have some of the other oddball diseases? And believe it or not, we've made the diagnosis of collagenous colitis recently in a young patient who was referred to me for resection, who got medical therapy.
Oh, that's interesting.
So I immediately send these patients to CGI, because in the overwhelming literature, you'll see that the majority of these patients may have misdiagnosis. And sadly, when they follow up after resection, many of these patients still have the same symptoms. I'm not really sure we're helping these guys.
No. It probably is an overlap with IBS, I suspect. Okay.
That's what I said.
Yeah. In terms of the post, you have a patient with uncomplicated diverticulitis which resolves. Do you think that we should routinely be doing a colonoscopy, or is there good evidence now that CT can rule out that perforated cancer? Or in your practice?
In our institution, our CTs are so superb that I have no doubt that we're able to rule out a cancer in these patients. But for those parts of the world where they don't have, the top of the line CAT scanner and all the things that we have, and dedicated radiologists looking at these, the FlexSig is not a bad way to go.
Because I was recently looking at the American College guidelines, and I think it was only of gastroenterology, which is only about a year or two old, and they still advocate the use of colonoscopy post resolution of diverticulitis, but actually the incidence of it is only about 1 to 2% of missed cancers. So hopefully,
I don't want to impugn their motives, but I suspect the motivation is more maybe other than clinical, and that's all I'll say.
Sure. And Phil, when you do your lavage, do you think there's a role for the use of an antibiotic solution?
No, I think it's bullshit. I just use heated saline.
Okay. And I mean, I know it's very controversial. What should you do at the time of laparoscopic lavage? By the way, I'm the opposite. I like to make sure there's no interloop abscesses. I need to make sure that there's no big hole in there. But as you say, there's no right or wrong answer to what you should do. I just get concerned.
And I suspect you will end up doing more Hartmans than I do, because you're going to open the hole up and expose it. And I know from my admitting CAT scan there's less likelihood of an interloop abscess that I'm going to miss based on my review of the CAT scan.
Okay, that's an interesting way of looking at it. And a couple of more questions, just looking at perhaps the future management of this. I mean, as you remember, Phil, Keiji Kodai from Japan in our London 2018 presented 14 patients who endoscopically their diverticular abscess were managed endoscopically. Are you aware of any other teams around the world who do this, and what's your view about endoscopic drainage of abscesses?
I heard that lecture. I was present at that meeting, and I know Keiji. He is an unbelievable surgeon with excellent skills and excellent judgment, and I believe his data. I would be afraid to try it in my country, and I know of no experience at present that's published in my country, in the United States, that does that. But I'm looking forward, again, to being in Japan, where Keiji is going to give us a follow-up on this data.
Sure. I mean, the interesting thing about that data, actually, there were, 14 patients, of which none of them required any further intervention. Now, by definition, these are complicated patients. And, from your talk and from our knowledge, these patients usually should have an elective resection somewhere along the line. But they say they don't require any other intervention.
Now, and then that raises the question, are we talking about the same disease?
Yes.
And I don't know that.
But anyway, as you said, that's the way it's been presented, and we trust that data. Final question. A colleague of mine is very keen on clipping diverticular disease or diverticulum to prevent progression of the disease or diverticulitis. Do you think that there's any mileage in this, or do you think it's just wishful thinking?
Well, when I first heard about this, I wondered, what else does he do with his time? Because many of these patients have multiple diverticula, and to clip the entire tick field to reduce the incidence of a perforation, I think will require a day per patient. And even if you're successful, most clips don't last forever, and I don't understand how that clip causes the necessary fibrosis to close the diverticulum down to prevent, obviously, a future perforation and peridiverticulitis. So I'm not keen on this, but I'm glad there's somebody out there that's willing to clip 100 ticks per patient.
I think, you know, it's time consuming, and I think the evidence for this will take years to prove, actually, to be honest with you, that it makes a difference.
Yep, I agree.
Anyway, on that note, Phil, fantastic. Thank you very much for recording this webinar, which took place on the 6th of February yesterday. Hopefully we'll put it up on our website very soon for everybody to look at. And hopefully we have recorded on this occasion. Thanks, Phil.
Thanks, Joe, and all the best to everyone in London. And look forward to seeing you in Yokohama, and also to seeing you at the next DDCRS in London, which is one of the great meetings. And for all of you that are listening to this webinar, please put those dates for future meetings in your schedule now. Take care, everybody.